The first unit, we're going to talk about today's medical assistant, chapter 30. This chapter is all about urinalysis. And I believe most of you have tested urine in the lab within the last month or so. So the chapter talks about most things that you're familiar with. The outline of the chapter is something I like to have everyone look at without even reading the chapter because it gives you an idea of what is considered to be the most important points. The urine is tested as a non-invasive way of attempting to see what is going on, and in the MA world, to understand the symptoms a patient is experiencing. Looking at the outline for Chapter 30, Urinalysis, important points have to do with what the urine is composed of, how urine is collected, how urine is analyzed, and then last but not least, the urine pregnancy testing. We've become fairly familiar with some of these terms in this outline from our S&T words, things like reagent, pH, leukocytes, red blood cells, white blood cells. So this chapter should be fairly straightforward for most of you. I decided to bring out the book so that you can take the book and take your study guide and realize how they mesh together. So the next part of this chapter talks about the learning objectives and procedures. Within the urinary system, there are conditions that cause polyuria, poly meaning many, and urea meaning urine. So a condition that causes a man or a woman to urinate excessively, and oliguria, where there's scant urine, there's not much urine. We're going to learn the terms describing symptoms of urinary system disorders. When it comes to how to collect urine, a first voided morning specimen is preferred, and we're going to talk about why. There's also something you're familiar with, which is called a clean catch midstream specimen. The next type of collection is 24-hour urine. And then if you get a urine specimen and you're busy in the care center and you leave your specimen sitting out on the counter in the lab for more than an hour, what can happen to that specimen? Analyzing the urine is something simply done. We can hold up our sample and visualize if the sample is outside of what is the normal color, if it has an unusual odor. And in our lab, we use what we call dipsticks to determine whether there's blood in the urine or glucose in the urine. And then lastly, when analyzing the urine, talking about the type of cells that might be found in the urine. Okay, so anuria, everyone is familiar with. Bilirubinuria, bladder catheterization, diuresis, dysuria, frequency, glycosuria, hematuria, ketonuria, ketosis, micturition, which is a terminology word as well, nephron, nocturia, nocturnal enuresis, oliguria, pH, polyuria, proteinuria, pyuria, renal threshold, retention, specific gravity, supernatant, suprapubic aspiration, urgency, urinalysis, urinary incontinence, and void. As I was going through those key terms, I'm sure a lot of you were thinking, hey, I've seen those before. And as we always try to mention is if you take the prefix and the suffix and you break them apart, more times than not, you're able to figure out the meaning of the word. So I'm going to move the page up here. And looking at composition of urine, we're talking about things like polyuria, which I mentioned above is an excessive increase in urine output. And then the opposite is oliguria, which is decreased or scanty urine output. And then that last word, which we did have as a terminology word, is micturition. That is simply the medical term for urination. These next words are repeated here, which we discussed earlier. They're words that you will become very familiar with. So how do we collect urine? Primarily, we give the patient a labeled specimen cup, and we instruct the patient to go into the restroom and to clean the area first, and then begin to urinate into the toilet. And when they are about midstream, they put the specimen cup under where the urine is flowing from, and they collect the urine. Okay, that's something we're all pretty familiar with at this point. It's important to find out if a woman is on her menstrual cycle, because there would be blood in the urine and that would be expected. If you need to get a urine sample from a young child, oftentimes we use something called a hat, which is just a collection. It's called a hat because upside down it looks like a hat, but what it is it's placed between the toilet seat and the actual toilet in order to have the young child sit and urinate into the hat, and then the MA will pour it into a specimen cup. And as most of you are familiar with, there is a pediatric urine collection bag that goes onto the infant's penis or vagina in order to capture the urine, and that is held in place by the diaper and a bit of a sticky cardboard-like end so that you can gently remove it and get what you need by pouring it into a specimen cup. Okay, so let's look at the case studies because I always find those interesting. So it talks about Yusuke Urameshi, who comes to your office with fever and chills, urinary frequency, which again, urinating quite often, and painful and difficult urination. The physician suspects that Mr. Urameshi has prostatitis and orders that clean catch urine specimen for a complete urinalysis, including a microscopic examination of the sediment. Mr. Urameshi tries to collect the specimen, but is able to collect only 5 mL of urine. He said he is worried about what is wrong with him, and he thinks his nervousness is making it hard to get a specimen. Mr. Urameshi says that it is probably just as well because he did not understand how to cleanse himself, and he is not sure that he did it right. So that's something you can think about as we're going through this unit. And I will be asking about it later on in this chapter. Remember, as a medical assistant, your primary duty is to instruct the patient on different procedures, and this is a fairly regular procedure. So earlier on, we talked about how important obtaining a first voided morning specimen is. The first voided morning specimen usually has the greatest concentration because it has been forming overnight. So that is your best opportunity to get something detected within the urine. And so obviously the patient is at home and you have given them a specimen cup, again labeled with the 2 unique identifiers and their information, and then they bring it into the office. If it is a larger entity like Kaiser or UC Davis or Sutter, patients can usually just bring it directly to the lab. Okay, so talking about that clean catch midstream again, we want to obtain as clean a specimen as possible, which is why you are instructing the patient to take a personal wipe and use it from front to back in order to clean the area to obtain that specimen. You want to remove as many of the microorganisms as you can from the sample that the patient is providing you with. Oftentimes, if a patient long-term just is unable to give you a specimen, they have to be catheterized. And a catheter is kind of like a giant straw. It's a tube that is inserted into the patient's urethra in order to get urine for your sample. The term suprapubic aspiration talks about taking a needle through the patient's stomach wall, abdominal wall, into the bladder to remove urine. Always, catheterization and suprapubic aspiration are done under sterile technique, and you've learned about sterile technique in the medical assistant laboratory. So this procedure 30-1, again, is something you should be familiar with as you are doing it or have seen it at least demonstrated by your instructor. And then this is one of the competency checkoffs you will have to complete. Very important is that paper charting. Most places have the electronic health record, but there are times when your electricity goes out and your computers don't work and the backup generators aren't working. So having familiarity with how to paper chart is very important. So please familiarize yourself with that. Again, we talked about labeling the container. If the patient does not bring the sample directly to the lab, the medical assistant is required to fill out the request and to include that request with the patient's sample. Okay, so the next point that's being discussed is how to obtain a 24-hour urine specimen. And a 24-hour urine specimen is done when a provider wants to find out what is going on with the patient who is experiencing symptoms that are not responding for whatever reason to treatment. Let's talk a little bit about some of the substances that may be measured in a 24-hour specimen. Things like calcium, cortisol, lead, potassium, protein, and urea nitrogen. This is a good way for a physician to get information about kidney stones, things like a creatinine clearance test. So in order to get a 24-hour urine specimen, obviously the container has to be large enough. You also have to encourage the patient to refrigerate their specimen. Usually that container is large enough to hold 3,000 milliliters. There are times when the patient will be instructed to stop off at the lab and pick up a special container that has a preservative in order to keep the quality of the 24-hour specimen. Some of the preservatives include hydrochloric acid, boric acid, acetic acid, and toluene. Anytime the container does contain a preservative, a hazardous chemical warning should be on that container. As I mentioned earlier with young children, they provide a hat, and I discussed how that is placed. It just can make things simpler. When you are instructing a patient on 24-hour urine collection, you are going to verbally explain it to them. You're also going to give them written instructions for them to follow. Oftentimes, much as the case study above, oftentimes a patient is very nervous and concerned, and they may be nodding their head yes to your instructions, but by the time they get home, they have forgotten what you said. So it's always a good idea to provide the patient written instructions as well. One of the other directions you should give the patient is to not drink alcohol during this collection period. Also, they should do this test when they plan to be home the entire time. And again, if the woman is menstruating or taking certain medications, they should not do the test during that time, or discontinue the medication at the time of collection. So let's talk a little bit about how urine is analyzed. Again, as a medical assistant, we in our lab use the urine sticks that we keep in a dark container in a dry area, tightly closed. In care centers, they actually have a machine that the stick is put into and read far more easily than you can do in our lab. So urinalysis is just the word urine with the E dropped, and analysis. It's taking a look at the urine in the lab, and you can look at that label, which we actually have printed out so it is more easily read. And that urinalysis that the MA does is simply reading off the label on the bottle. In the lab, they take a look at chemicals. They test for the presence of chemicals. Some of you who have had drug testing done for your going out to externship are familiar with that. And then microscopically, what they do is they use kind of like an eyedropper, and they take up some urine, they place it on a microscopic slide, put a cover over it, and look at it under the microscope. If that urine sample that you have been given, you are unable to test it immediately, you should put it in a refrigerator, much like we have in our lab. It is designated only for specimens and not for food. Again, your label must be there, clearly identifying whose urine it is and what time you have collected it. So having your urine, if you let it stand at room temperature, remember this is one of the questions in your earlier that we went over earlier is, sorry, I was trying to get the highlighter. And let me try this because it is kind of nice to have this important point highlighted, but it's not going to let me do that, is it? Oh, it did. Okay, so again, urinalysis should be performed on a fresh or preserved specimen. If a specimen cannot be examined within an hour, it should be refrigerated and labeled, clearly labeled, and then returned to room temperature before it gets tested. See, now that one didn't work. Sorry. Everybody's probably amused by Dr. V not being able to properly highlight in the book. There we go. Nope, still didn't work. Okay, I apologize. I'm trying. Let's see if I use a different color. Nope. Okay, I'm giving up. So again, sometimes chemical additives are used to preserve specimens. So here we go, talking about what happens if the urine is left standing for an hour or so and left standing at room temperature. These are the kind of things that can happen. I'm going to do my best to make the highlight again. Okay, bacteria in the environment can get into the urine specimen and convert bacteria to ammonia. Then the pH of the urine can change. The bacteria can end up giving you a cloudy specimen because you have an increase in nitrite. And urinary casts decompose after a period, and that could be problematic. So leaving it standing at room temperature, not a good plan. So the next type of analysis we do on urine is the physical exam. What does it look like? What color is it? The normal color of urine is kind of a straw or yellowish, light yellow to mid-yellow color. When you have urine that is dark red or too pale, too dilute, that is a physical characteristic of urine. You want to look at the color, the appearance, and the specific gravity of urine. Those things are important, and I'm going to highlight them. Okay, the color and appearance of the urine can just be evaluated by looking at it, right? The color and the appearance. The specific gravity is something you will test with your dipstick in our lab. So talking about the color, the normal color of urine can range from almost colorless to a dark yellow. I'm going to try to highlight that. Here we go. Nope. Thought I had the hang of it. Dilute urine, that's if someone drinks a lot of water, your urine will be more dilute than normal. And concentrated urine, kind of like first morning specimen, can be a darker yellow. Remember that food and fluids are not ingested when you're sleeping, and so your urine is more concentrated. When you drink a lot of water during the day, your urine is more dilute. So the color of urine has to do mainly with, I'm going to try to make a highlight here, mainly with a yellow pigment called urochrome. Chrome means color, right? I'm going to try to highlight that again. I think I did it. Yes. And this urochrome has to do with hemoglobin breaking down. So depending on when the urine sample is collected, you may see a difference in the intensity of the color. Having a different color other than the normal range can give the provider information about what he or she should do in order to further test the urine. Okay, again, looking at the urine, the appearance is done at the same time as you look at the color. Fresh urine is usually clear, transparent. You can see through it. It becomes cloudy on standing too long. Cloudiness in urine may be the result of bacteria, pus, blood, fat, yeast, sperm, and fecal contaminants, mucus threads, and sperm. Once they take that, make a slide of the urine and do a microscopic exam on a cloudy specimen, they will find out what is causing the cloudiness. The most common cause of the cloudiness is something called a UTI. UTI is a urinary tract infection. Oftentimes when you are working as a medical assistant in a care center and you as the MA notice that as you're pouring out just a little bit of urine from your specimen cup onto your dipstick, is you may notice an irregular odor. You've already noticed the color or the cloudiness. Best practices is not to throw away the rest of the specimen, but rather to put it in the refrigerator, again labeling the time it was collected, because your provider will more than likely ask you to get something called a C&S. C&S stands for culture and sensitivity, and then you have that specimen available to do that. Again, that's called best practices. So as I mentioned earlier, the odor of the urine is something that you need to pay attention to as well. If urine smells quite a bit like ammonia, that's not a good thing. Okay, if it smells fruity, it could be because there are ketones in the urine. And talking about that UTI, the urine will have a foul smelling odor, and it becomes worse on standing. There are certain foods that can cause the urine to have a change in smell, things like asparagus, and that's something to be aware of. So if when you're testing that urine, you can often ask the patient if they had certain vegetables to eat, and that would give you an idea of what the odor that you had identified was, and you can note that on your evaluation. So the last thing that you as an MA look at is specific gravity. And the specific gravity measures the weight of the urine compared with the weight of an equal volume of distilled water. Remember, that's one of your terms for the week. Your specific gravity gives you information having to do with the amount of dissolved substances in the urine, and really talks about how the kidneys are working. And as you know from the chapter on the urinary system, when the kidneys aren't functioning appropriately and can't concentrate the urine, you can have a situation such as chronic renal insufficiency, diabetes insipidus, and things like hypertension. So specific gravity is a very important measurement to the physician. So I'm going to highlight what is normal specific gravity. Maybe. Dang it. Thought I had this. The normal specific gravity of urine ranges from 1.003 to 1.030. Usually it is found to be 1.010 and 1.025. That better work. There we go. So again, remember, it is compared with distilled water, and the specific gravity of distilled water is 1.000. The more you drink, the more your specific gravity can change. Urine that is diluted will contain less dissolved substances and therefore have a lower specific gravity. When urine is more concentrated, the specific gravity will be higher. So it does mention here in the next paragraph that we use that reagent stick or the dipstick to look at what a patient's urine specific gravity is. So procedure 30-2 explains exactly what I was discussing. However, I'm not a fan of this picture because what this does is makes that urine sample unusable for culture insensitivity because it has become unsterile when the entire stick has gone into the urine. Okay, so best practices is to pour out some of the urine onto the stick, obviously over the sink, and keep the rest of the specimen that the provider might want you to use later. So again, this procedure is simply something you have done or will do in the lab very shortly. And this table right here talks about the amount of time that you wait to read the results on the side panel here. Okay, so now that you understand about how urine is collected and how it is looked at from the MA's point of view, want to talk a little bit about chemically looking at urine. So when urine is looked at chemically in the lab, it's to determine whether there is something like a urinary tract infection, a problem with kidney function overall, and liver function. Anytime there are abnormal amounts of things like blood in the urine, glucose in the urine, nitrite in the urine, it is an indication that something is not functioning right. Something is quote unquote wrong with that sample. I'm going to talk a little bit about qualitative versus quantitative. Qualitative is looking at what type of substances are present in the urine and gives the provider a fairly good interpretation of that. A quantitative, quantity being amount, is how much of that substance is present in the body. Obtaining that quantitative result on a urine specimen usually involves something far more complex than we have in our lab. Okay. If the provider wants to do something more involved than that dipstick, as I like to call it, there are urine testing kits. And these kits are used because the reagents are there already pre-mixed and measured, and they provide the doctor with right away, here's your answer of what's going on. And that the doctor may need to do more examinations. Okay. If you are in an office where they have the involved urine testing kit, you need to make sure you are familiar with how to use that specific test. Different offices use different test kits, and as a result, you want to be familiar with the one that your provider is using. So looking at this next case study, what would you do and what would you not do, that I like to have you folks look at and discuss prior to the end of the lecture. Here we have an MA, Nora Sheraton, and she's at the clinic where these urinary frequency, urgency, dysuria, and blood in the urine are tested frequently. So she has been having problems. sorry, Nora Sheridan. I got ahead of myself. Nora Sheridan is actually a patient, and she is at the clinic having these symptoms. Urinary frequency, as you know, is polyuria. Urgency, feels like she has to urinate all the time. Dysuria, that's painful urination. And hematuria, blood in the urine. She keeps having these problems. She wants to know why these infections continue to occur, and is there something she can do to prevent them? Okay, so now Linda Profit is actually the MA who happens to work for a urologist. So she works in the urology practice, and she's responsible for having charts ready when the patients are seen and for conducting their urinalyses. In order to do that, she has to become super familiar with the expectations of the provider she's working for. So she says when she first started working for the office, she had to learn how to work with transrectal ultrasound of the prostate in case the ultrasound technician was sick. When she was retired, she inherited the position whether she wanted it or not. At first, she didn't like doing it because she was nervous and she would forget in what order things needed to be done. She says her physician was understanding and would help by talking her through it. The main reason she was nervous is sometimes patients have trouble and oxygen needs to be administered and IV lines need to be administered. As you know, neither of those are things that an MA can do. Okay. Time, practice, and confidence in myself have improved my nerves even with the occasional emergency situation. So again, this particular MA does not work in an internal medicine practice. She works in a specialty practice, and she has had to familiarize herself with how procedures are done in this office. So let's talk a little bit about drug testing, which is timely because, as I said, there are a few of you getting ready to go out to externship, and so having an understanding of how the drug tests are done is a good thing to know. So drug testing in the workplace is something that has become quite frequent, and we as a school have to make sure that our externs have passed a drug screening before they go out to externship. In order to do that, and I'm sure some of your classmates can talk in detail about this because they just went through it, you go into a lab and you have to give them everything, your purse and your cell phone, and they lock everything up, and you're given a specimen cup, and you go into a room that just has a toilet, no place to wash your hands because water can dilute a urine sample, and that can be suspect. So normally urine is tested. If there is something found in the urine, then they can request further testing. If a student in externship, and by the way, this is not just for medical assistants, every student from Gurnick has a drug test before they go out to externship. And it is far easier to do a urine test than to do a blood test, even though a blood test can be more exact as to what is contained, what type of drug is contained in a student's system. So once you give that urine specimen to the medical assistant or the assistant at the drug testing lab, they make sure that No one else handles it. They take it from the point of either going into the lab or sending it out. It's called a chain of custody. It is very important because I digress. Most important is for it to be labeled with your information. Second most important chain of custody is that you are who you say you are. Then they want to make sure that that sample is not tampered with. And they either seal the container, as I said, or take it into the lab that is on the premises. If they need to send it out, they would again do as any assistant would do, is refrigerate it so as to not have the urine breakdown occur. So there are some disadvantages of urine drug testing in that you can have a positive test result, excuse me, that there is a drug in the urine, but it really doesn't give details as to when that drug was taken, and that can be problematic. Okay, so pH, you learned about pH, I believe, back in the chemistry chapter of HBI, but for the new students, they may only have familiarity with the word pH learned in terminology. And it talks about how acid or basic alkalinity of a solution, that pH goes from 0 all the way up to 14, and neutral is in the middle. The lower that number, the more acidic a sample is. The higher the number, the more basic or alkaline the sample is. So remembering back to basic functions of the kidneys regulate, my arrow is shaking, I don't know why. The kidneys regulate your acid-base balance. To get a good pH reading, you should always do, again, a fresh sample. Remember, we talked about having a fresh sample. Again, if the urine sits for a long time, it becomes more alkaline as that urea is converted to ammonia because of bacteria. The pH of urine can normally range, I'm going to highlight that, from 4.6 to 8.0. I really don't know why my thing is shaking. Stop it. And then I'm going to say make highlight. There we go. So 4.6 to 8.0 is normal. If you have an abnormally high pH reading, it means the urine is more alkaline, and again, could be a bacterial infection of the urinary tract. Glucose in the urine should not be there. Period. Should not be there. The word for glucose in the urine is glycosuria. Glycosuria. I'm going to highlight that. Let me highlight it in yellow. Okay. Or not. Sorry. Glycosuria. If somebody has glucose in the urine, the most common reason is because they have diabetes, but that's not always the case. Okay, protein in the urine is called proteinuria. Protein in the urine. Again, you would know that by just knowing the two words involved. protein is not normally in the urine. And so if protein is found in the urine, that may require further testing. Sometimes with elite athletes who do like triathlons, 26 miles of running and 112 miles on their bicycle and a couple miles swimming. That's strenuous exercise. Primarily, though, protein in the urine will indicate problems with the kidneys, and that's things like the glomerular filtration, renal disease overall, bacterial infections in the urinary tract. The provider again will order additional tests to determine what's going on and the reason for the protein in the urine. Ketones. Ketones in the urine, most of you are familiar with the term keto diet. Ketones in the urine is what they strive for. And ketonuria is the term that talks about ketone bodies in the urine. And that may be due to, as it says here, a diet, I'm going to highlight it again. Conditions that may lead to ketonuria include uncontrolled diabetes mellitus, starvation, and a diet composed almost entirely of fat. Let me highlight that here, hopefully. Apparently not. Try it again. There we go. I don't know, sometimes it works and sometimes it doesn't. Another reason I'm doing this is a lot of people are not familiar with some of the cool things that are available to you in your ebooks. That highlighting is one. Another one is making a note. So you can put a note somewhere. Hang on. It's not letting me put my note. Oh, maybe I have to highlight it again. Show it to you, but it's not going to work for me. There we go. There we go. So make a note. I'm going to put keto diet with an exclamation point. Okay, and then I'm going to put that there and see how it's thinking about it. The next time you open your chapter 30, you're going to have that little note pop up. So the next thing, and again, all of these that are labeled in this dark red are things that you are looking at and the label when you are checking out your dipstick after the allotted time that you're supposed to wait. And we do have timers in the lab. Okay, so bilirubinuria is the presence of bilirubin in the urine. When there is bilirubin in the urine can turn a yellowish brown or a green, as well as some yellow foam forming when you shake the urine. So that's bilirubinuria. I'm going to highlight it if I can. And things like, come on. Things like gallstones, hepatitis, and cirrhosis of the liver can result in bilirubin in the urine. So again, important for the provider to be aware of that. So I know I'm interrupting myself a number of times, but each of these things are non-invasively showing up. And the MA has discovered those in order to let the doctor know how he or she should proceed. So always remember how important the MA position is. The next item you're looking at is something called urobilinogen. And that, remember, we talked about bilirubin going into the liver and into the intestinal tract, and bacteria being converted. So that also should not be in the urine. Okay. However, if there is too much bilirubin, you end up with uro meaning urine, bilinogen excreted in the urine. Conditions that would cause this, going to try to highlight again, please, yes. Conditions that would cause this are infectious hepatitis, that's another liver condition, cirrhosis, a liver condition, congestive heart failure, and infectious mononucleosis. So again, more non-invasive indications of things going on simply by getting a urine sample. Blood in the urine, so you're familiar with the fact that something like a menstrual period could put blood in the urine, but other things that might cause hematuria could be cystitis, bladder tumors, kidney stones, and other kidney disorders. So normal things like menstrual blood, however, a lot of abnormal things. All right, just two more items we're looking at in the urine. Nitrite in the urine. If there is nitrite in the urine, it is best seen when you have that first morning sample. If you leave a sample sitting out for a long period of time, as you know, you can get a false positive. So this nitrite screening, let me highlight this. And this in particular causes the physician to want to do something called a culture. And I mentioned that earlier on, the C and S. The last thing we're looking for is leukocytes. Leukocytes is one of your terminology words, and having leukocytes in the urine is leukocyturia. Difficult word to say, not a good thing to have happen. Usually it's due to a problem in the urinary tract and or the kidneys. And I want to highlight some of the conditions. Talks about acute and chronic pyelonephritis, cystitis, urethritis. Okay, let me highlight those again. Okay, so they do make special dipsticks or reagent strips that permit chemical detection of intact or broken leukocytes in the urine. The advantage of detecting that lysed leukocyte is you can't see white blood cells during your microscopic exam of your urinary sediment. So having that is especially important. So, for instance, an office that saw a lot of women in the urology department would have that special strip. So talking again about those dipsticks, very, very common in the office. They have quite a number of them locked in their labs because they use them so often. And the urine specimens are very common in the urology office that I worked for, every single patient that came in, whether they had symptoms or not, were required to provide a sample. So this talks a little bit more about how you should use those dipsticks. Like anything else, you want to make sure that your bottle of test strips are not expired. You want to make sure that they are stored properly, and you want to only take out one at a time. Okay, so this is mainly talking about QA and QC. QA is quality analysis, and QC is quality control. And again, if something's expired, you may get a false result. Okay, oftentimes for instance, a urology office, the first MA in for the day is required to run QA, QC procedures to make sure that all the equipment is appropriately functioning, that the dipsticks that they have on hand are still within acceptable use time. Okay, so here's the cool machine I told you about that you can simply pour the urine sample onto the dipstick and then stick it in a urine analyzer. And this automatically does what you're doing with the timer and your dipstick in the lab. So again, we spoke about microscopic exam of the urine. That is a procedure here. Obviously, as you can see, you wear gloves. You have everything that you need ready before you start your procedure. That is procedure 30-3. Okay. And then your lab report would look something like this. This, again, is not something MAs routinely do. However, if your particular provider requires that you do that, you get familiar with that right away. Okay. So this part of the chapter is talking more about what red blood cells look like under your microscope and what might cause different cells in your urine. Excuse me. Things like red blood cells would be seen in trauma, in some types of bleeding diseases. So to the right on this chart are nice illustrations of what things would look like under your microscope. Again, this mostly occurs in the laboratory. If you happen to work in an urgent care center, your provider may ask you to provide a slide, but usually he or she will do the analysis. So talking about red blood cells, white blood cells, epithelial cells, casts and crystals, and then you may also see mucus threads, yeast cells, bacteria, parasites, and spermatozoa. So here we are back with Linda. Linda Prophet is the medical assistant, and she was talking about as a student she was particularly shy, and she had to learn how to communicate with them so that she could discuss information with them more freely. Again, some results, the reason people will come in to be seen by their provider is because they have a urinary tract infection. You do teach patients about how they can avoid urinary tract infections. You also need to provide them with written information. And again, as we emphasize throughout the program, you only provide them with information that is approved by the care center you're working for. Okay, and so the last part of urine testing has to do with pregnancy testing. And pregnancy testing in the urine is something women can do at home. And if they want to make sure that their results are accurate, they can come into the office and have a pregnancy test done. Best time to do a urine pregnancy test is with your first morning specimen. What they're looking for in the urine is a substance called HCG, which is human chorionic gonadotropin, and that is present when there is a fertilized egg in the woman's body, and so that hormone is released, and you can see it. It would be discovered with a pregnancy test. Another way that in the doctor's office pregnancy can be detected is with something called an immunoassay, and this is to give an immediate result, and you will have a visible reaction. Okay, let me highlight that. Yay. Okay, so we use a specific test in different offices. We have most common is something called the Quick View. In procedure 30-4, I believe you folks did that this past week, pregnancy test, and where you would have a positive is you are depending on the type of kit. So remember, always open up the instructions in whatever kit you're using so you make sure you have a clear understanding of what results you're looking for. Okay? It talks about guidelines for urine pregnancy testing. Again, another case study. Rita Lavelle is the patient. She is 8.5 months pregnant and has her prenatal appointment. Lately, she has been having difficulty obtaining a urine specimen at the medical office because of her enlarged abdomen. At her last appointment, the office provided her with a container so she could obtain her specimen more easily at home. Again, first voided urine specimen. Let me highlight that. So in this case, her dog ate the specimen container the office provided, so she used an empty peanut butter jar. The urine test results showed her glucose level is normal, but her protein level is 4+. Until this time, all of her urine tests have been normal. She's concerned about her baby. She was cleaning her bathroom cabinet yesterday, came across a pregnancy test. Just for the fun of it, she decided to run the test. The results were negative. Now she is worried something is wrong. Rita says she has not been sleeping well at night and that she has noticed more Braxton Hicks contractions, but the baby has been kicking and moving as usual. So these are interesting case studies because they are things you will see and hear when you're in your office. So the last part, which is the last part of this chapter, talks about the serum pregnancy test. Serum refers to blood, and this is a more exact test for the presence of HCG. And it can also detect pregnancy earlier and greater accuracy. It usually would be positive around the 8th day after fertilization, which is 6 days before the first missed menstrual period. Okay, so now remember earlier we talked about the different case studies. Here are some examples of what appropriate answers might be. In case study number 1, Mr. Urameshi. Remember, he was very nervous, and so what did Linda do? She took some time to calm him down, reassured him the physician will do everything he can to make Mr. Urameshi better, offered him something to drink, told him that drinking the water might make it easier for him to urinate, went over the directions again, and asked him to try again. Okay, what did she not do? She did not tell him he was not trying hard enough. In the second case study, had to do with Nora and her frequent urinary tract infections. So Linda did ask Nora whether she takes all of her antibiotics as prescribed. She explained to Nora in terms that she can understand why women seem to be more prone to UTIs. She also explained to Nora that things she could do to help prevent that. Gave her a brochure, remember, office accepted brochure. She also told Nora that the physician is not legally or ethically permitted to call in a prescription for her UTI without in fact seeing her. She explained it is the best interest of her health care to be seen by the doctor. What she did not do is she did not tell Nora that she could not test her urine at home. Okay? And then in that last case study, Linda told Rita, who used the peanut butter jar, that perhaps the peanut butter residue could have affected her test results. She then asked her to try collecting a specimen here in the office. She encouraged her, if something happened to her container, to come back in or stop at the lab and pick up another container. She did tell Rita several things could have caused her pregnancy test to be negative. Explained how that test could have been expired or not stored properly. She reassured her that women have trouble sleeping during the last month of pregnancy. So again, she wanted to calm her down. She let her know that she would let the doctor know all of Rita's concerns. But what she did not do is she did not make Rita wrong for using the peanut butter jar, and she did not ignore or minimize Rita's concerns. So again, these case studies really emphasize how important an MA's position in the office is, and that is something that is often downplayed, but I love the case studies and the responses simply because you as an MA can make the difference of a patient staying with your provider. So in the very beginning of the chapter, there was an explanation of how to pronounce the words in this terminology review. And now here at the end, I don't know if this has a label. No, it does not. It just says terminology review, but it's alphabetically all of the words from the beginning of the chapter and those that we have discussed here in this lecture. So, wanted to make sure you were exposed to this lecture so that you can review it in your distant education. If you want further information about any of the subjects discussed in the chapter, there are a number of sites recommended for you here. So with that being said, make sure you know your definitions, and that's all, folks.